بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will handle this lecture, the imaging of the formation of the cerebral cortex and the abnormalities which will result from distorted cortical formation, a group of diseases previously known as neuronal migration disorders. And these disorders were not fully understood until recently with the development of MRI. And in order to understand these abnormalities, we should know that by the seventh week of gestational age, there is mitotic activity in the subependymal layer of the ventricular wall. And here is a representation. You can imagine that this is the wall of the ventricle, and there is a proliferation or mitosis of the cells in the wall of the ventricle, the subependymal layer, to form the cells which will migrate on what's known as the radial fibers, and this migration continues until these cells will reach the cerebral cortex. Then there are some abnormalities and insults that may disturb the cell proliferation, migration, and organization, and these collectively are possible causes, not definitive causes. They include infections, metabolic abnormalities during pregnancy, ischemia, genetic and chromosomal abnormalities. One of these insults or more than one of these insults can result in abnormalities in the neuronal migration and proliferation. So a collective group of diseases will result, and these are they have a specific imaging criteria, and also they present clinically by specific symptoms. The most important of them is the presence of seizures, and sometimes the patient may show developmental delay and mental retardation, but the most important presenting symptom in this group of diseases is seizures. Then we have three stages of the cortical formation. The first is the stage of proliferation, where the subependymal cells proliferate and divide to produce so many cells that will migrate on the radial fibers. And this is the stage of migration to reach the cerebral cortex. And whenever they reach the cortex, they organize into specific parts, and this is the final stage, which is the stage of organization. Then we have three definitive stages that can be subjected to any abnormality. The stages are the stage of proliferation, the stage of migration, and the stage of organization. Starting first by the stage of proliferation. Whenever there is an insult that has resulted in abnormal proliferation in the subependymal cells, this will result in an abnormal size of the affected brain tissue, and you got two very well-known diseases, which are the hemimegalencephaly and the cortical dysplasia. Then also congenital tumors may result from increased proliferation of the cells, and these include the ganglioglioma and the dysembryoblastic neuroepithelial tumor. Then starting first by the hemimegalencephaly, which is a rare congenital disorder of course unknown etiology, and it accounts to 0.2% of the causes of childhood epilepsy or seizures. The main abnormality in this hemimegalencephaly is hamartomatous overgrowth of a part or the whole cerebral hemisphere. There are so many types of this hemimegalencephaly, but we will discuss the commonly seen type in the clinical practice, which usually affects one cerebral hemisphere. And you see that this is the left cerebral hemisphere, which is good, and the right cerebral hemisphere is abnormally large, and there is abnormalities in the white matter of this hemisphere. There is thickening and the broadening of the gyri. There is enlargement of the lateral ventricle of this cerebral hemisphere, and the most important sign for the diagnosis is a straightening of the frontal horn of the lateral ventricle. You know, normally the frontal horn of the ventricle is facing laterally, but the frontal horn of the hemimegalencephalic hemisphere is pointing anteriorly. Then straightening of the frontal horn is one of the signs that can help you to diagnose this pathology. And this is a hemimegalencephaly by CT affecting the right cerebral hemisphere. The right lateral ventricle is large, and the frontal horn of the ventricle is straightened. There are thickening and the broadening of the gyri, and you can also see few cortical sulci on the surface of the cerebral hemisphere. You should know and you should remember that the most important presenting symptom in all this group of diseases is seizures. It may be associated with developmental delay, hemiparesis, hemianopia, and other presenting symptoms, but the most important one is the seizure. Then this is an MRI of a case of hemimegalencephaly on the right side. And you can see that the right cerebral hemisphere is large compared to the left one. The ventricle is large compared to the left one. The frontal horn is straightened compared to the left one. And the cortical gyri and sulci, the gyri are thick and broad. Look at this gyrus, for example. Look at the normal sulci and gyri on the left side. And also look for the white matter. By the age of 4 years, there should be full myelination of the white matter, and it will appear dark in the T2 weighted images, as you can see here. But the white matter of the affected hemisphere looks bright due to the presence of abnormalities in the white matter. Then you got enlargement of the cerebral hemisphere, enlargement of the lateral ventricle of the same hemisphere, shallow sulci, and enlarged gyri. This is known as brachygyra. We will discuss it immediately. Then the calvarial bones on the affected side may be thickened, and the falx is usually displaced to the opposite side because of the enlargement of the hemisphere itself. And if you have CT scan, you can see sometimes calcification in the white matter. And this is also a case of hemimegalencephaly affecting the right cerebral hemisphere. The hemisphere is large, the ventricle is large, the frontal horn is straightened, there are thickening and broadening of the gyri. Then this abnormality is usually associated with brachygyra, which is thickened broad gyri, as you can see here, or may be associated with agyra, which is known as lysencephaly, or polymicrogyra, as I will mention during this lecture. And this is the CT scan of a hemimegalencephalic right cerebral hemisphere, and you see that the ventricle is a little bit dilated and the frontal horn is straightened. There is enlargement of the hemisphere, eccentric position of the falx, and abnormal hypodensity of the white matter. And this is a left cerebral hemimegalencephaly. The hemisphere is large, the frontal horn is straightened, abnormal density of the white matter, the ventricle is dilated. And sometimes you can see focal megalencephaly of a lobe. And in this case, you see that the frontal lobe is abnormally large. There is a thickening and the broadening of the gyri, and also you can see a straightening of the frontal horn of the right lateral ventricle, which looks larger than the left one. Then you remember that hemimegalencephaly usually affects the whole hemisphere, but sometimes it can affect a part of the hemisphere. Then the second issue here is the focal cortical dysplasia, and this is abnormal arrangement of the neurons in the affected cerebral cortex. And the incidence is about 5 to 15% in patients with seizures. I hope you remember this very much. Then by CT, it may be difficult to appreciate this focal cortical dysplasia, but by MRI, you can see an area of abnormal signal within the cerebral cortex. And in order to differentiate this from the infarction, for example, and the gliomas, some types of the gliomas, you can see the cortical sulci going through the affected area of the cerebral cortex. This is one of the helpful signs. But you remember that the area of cortical dysplasia will show abnormal signal, high signal in the T2 and the FLAIR images, as you can see here. And this area will not exert any mass effect. It will not enhance if you inject the contrast material. And you see here an area of focal cortical dysplasia, which is not usually appreciated well in the T1 weighted images, but you can see it in the T2 and in the FLAIR images as well. And because sometimes the focal cortical dysplasia may simulate a neoplasm, especially the diffuse type of astrocytoma, then you can see a lesion here. And this lesion is hardly seen by CT, but it can be appreciated in the MRI T1 weighted image, but it is well demonstrated by the FLAIR images. Then sometimes you may need to have a biopsy from the lesion to confirm the possibility of focal cortical dysplasia and to exclude the possibility of a neoplasm. Then we came to the congenital tumors, which are the dysembryoblastic epithelial tumor, which is known as the DINET, and the ganglioglioma as well. In these tumors, in this particular tumor, this is a low-grade tumor due to abnormal proliferation of the subependymal cells, and most of these lesions are located in the supratentorial area, usually in the temporal lobe. They appear as well-defined wedge-shaped lesion, and this lesion will show low signal in the T1 and high signal in the T2. If you inject the contrast, it will not enhance, and many times it can be mistaken for an infarction. But you should remember that these lesions do not contain calcium, they are not surrounded by edema, and they do not show contrast enhancement. The most important sign to diagnose these two tumors is the remodeling of the calvarium. These are cortical lesions and they are slowly growing and they indent the cortex from its interior aspect. Then many times you see these tumors associated with the scalloping of the inner table of the skull. And this appearance will help you to predict the nature of this tumor. Then you see a lesion which is bright in the FLAIR, bright in the T2, and low signal in the T1. And if you inject the contrast, it will not enhance. It may simulate an infarction, may simulate diffuse astrocytoma, but you remember the scalloping of the inner table of the skull and the clinical presentation of the patient with seizures will help you to predict the nature of the tumor. This is a 14 years old girl with seizures, and the brain CT showed the hypodense area here. The MRI showed a low signal lesion in the T1 and high signal in the T2, and this is post contrast. The lesion is not enhancing, but the most important finding, as I mentioned, is the scalloping of the inner table of the skull. Then the same applies for the ganglioglioma. Ganglioglioma is a lesion which also occurs in the supratentorial area, and 85% of the lesions occur in the temporal lobe, but calcium here is well documented. Then you see a lesion in the supratentorial area and containing calcium. If you inject contrast, the lesion will enhance. Then you cannot differentiate it from oligodendroglioma, for example. But you remember that the scalloping of the inner table of the skull is one of the helpful diagnostic criteria in these two particular types of tumor, the ganglioglioma and the Dennett. And here you see a lesion which is of low signal in the T1. You see the calvarial scalloping, high signal in the T2, and after contrast enhancement, it will show heterogeneous pattern of enhancement. MRI is less sensitive than CT for detection of calcium. Then we came to the next step, which is the disorders of migration. The subependymal layer proliferated well, and the cells are now ready to migrate. Then came the disease and disturbed the migration. This will result in abnormal location of the gray matter before reaching the cortical surface of the brain. And this is known as heterotopia. And heterotopia means that there is ectopic location of the gray matter heterotopia. We have many types of this heterotopia or gray matter heterotopia. The first one is known as band heterotopia, and you see in this figure that some of the cells are migrating towards the cortex. Many of the cells reached the cortex and others did not reach the cortex. They form a second cortex below the original one. And then this disease is known as double cortex or known as band heterotopia. Then you see cortex, then white matter, then another cortex, then another white matter. And this is an example by cadaveric section and by MRI. And here you see the original cortex, and you see a band of gray matter below the original cortex with a band of white matter in between, then white matter around the ventricle. This is known as the double cortex or the band heterotopia. And this is also a good example, and you see this very well presented band of gray matter, similar of signal intensity to the gray matter of the cortex. Then this is known as the band hetero. Sometimes you may got three bands or more than this, but the same name applies for the disease, which is band heterotopia or the double cortex. And here is the T1 weighted image and the T2 weighted image. And you should note that the band will be of similar signal intensity to the cortex in the T1 and similar signal intensity to the cortex in the T2 weighted image. And the second type of this heterotopia is known as lysencephaly or agyra or a smooth brain. And here you do not see any sulci or gyri. And you see only on the surface of the brain the sylvian fissure, which is short and more vertically oriented, giving the brain the figure of 8 or the hourglass configuration. And here is an MRI of a case of lysencephaly. You see that the cortex is very thick. You know, the thickness of the cortex is about 2 or 3 millimeters. But here, the cortex is about more than 1 centimeter. You do not see any sulci or gyri on the surface of the brain, but you see the small vertically oriented sylvian fissures. And here is a case of 9 months old boy with The white matter is not yet myelinated, and so it contains a lot of water. Then the surface of the brain is smooth. This is the sylvian fissure, which is short and more vertically oriented. And sometimes, in some cases of lysencephaly, you can see few sulci and gyri like this. And you see this gyrus, and this is the sulcus. You can see the thickness of the cortex and the broadening of the gyri. You remember that the thickening and the broadening of the gyri is known as brachygyra, and this is the step between lysencephaly and the polymicrogyra, as I will mention. And you see here the smooth surface of the brain, marked thickening of the cortex, and sometimes you can see hypoplasia of the corpus callosum. This corpus is good, and also you may see hypoplasia of the brainstem, but this brainstem also looks good. Then in some cases, as I mentioned, you got thickening and the broadening of the gyri, and you can see few sulci. And this is a step more or less severe than the lysencephalic brain. Then there is some way or a distance between the lysencephaly and the brachygyra. This is the normal appearance of the cortical sulci and the gyri in the normal brain. You see how many sulci and the cortex, this is the usual thickness of the cortex. And if you look to this example, you can see that the gyri are very thick and they are broad as well, and they are few in number. And this what we call the brachygyra. Then agyra, brachygyra, the agyra means that there is no sulci or gyri, but the brachygyra means that there are sulci and gyri, but they are few and they are very thick. Then sometimes you can see the surface reconstructed images to look carefully for the gyri, which are markedly thickened and broadened. Then we came to we have actually three types of gray matter heterotopia. The ectopic location of the gray matter may be identified into one of three sites. The first one we have finished is the band heterotopia, or the double cortex, in which the cells, some of the cells migrated to the cortex, other rested before reaching the cortex, forming a band of gray matter underneath the original cortex. The second type is known as focal heterotopia, a group of cells forming a focal or a mass-like lesion stop the migration within the white matter, and they form a focal mass within the white matter, and this focal mass will show exactly the same signal to the cortex in the T1 and in the T2. They are normal brain tissue and they do not enhance with contrast material. The third type is arrested cells within the wall of the ventricle, and this will form multiple nodular lesions in the wall of the ventricle. This type is known as subependymal heterotopy. In all types, the heterotopic gray matter will show the same signal to the cortex in all pulse sequences. In the T1, it will appear similar to the cortex. In the T2, it will appear similar to the cortex. Then there is a well-known disease where you can see multiple subependymal nodules, which is the tuberous sclerosis, and I will mention how can you discriminate between both. This is a case of subependymal heterotopia with multiple gray matter nodules in the wall of the ventricle, and they are exactly similar to the cortex in the T1, similar to the cortex in the T2, and if you inject the contrast material, the nodules will not enhance. But look to the tubers of the tuberous sclerosis. In the T1 weighted image, they appear a little bit bright. If you inject the contrast, they will enhance. If you have the T2 weighted image, they will appear dark because of the presence of calcium. But here, the nodules are similar to the cortex in the T1 and in the T2. If you inject the contrast, they will never enhanced. And this is the focal heterotopia, where a collection of cells will accumulate within the white matter forming a mass, and this mass will also show the same signal intensity to the cortex in all pulse sequences. This mass is not surrounded by edema, it does not exert any mass effect, and it does not show contrast enhancement. The final stage of cortical formation is the stage of organization, where the cells have proliferated and migrated well, reaching the final destination in the cortex. Then the organization of these cells has faced some problems, resulting in two major abnormalities. The first one is polymicrogyra, and the second one is known as schizencephaly. Polymicrogyra means that there are numerous gyri and numerous sulci. This polymicrogyria is usually focal, and these are the common sites for location. The most common site is around the sylvian fissure. As you can see in this example, they compare this area by the opposite area. Here you see too many cortical sulci and gyri. This is known as polymicrogyra. You remember that the main presenting symptom should be epilepsy, and sometimes you can see this abnormality on both sides, and you see it in the frontal lobe or the parietal lobe, and least frequently in the occipital lobes. Then polymicrogyra means that there are abnormal increased number in the gyri and the sulci. Then the commonest location, as I mentioned, is around the sylvian fish. Then if you look here, and I will enlarge this image, and if you look around the sylvian fissure, and you can see too many small gyri bordering the site of the sylvian fissure bilaterally, and this is polymicrogyra around the sylvian fissures. Also here, and you see this amount of gyri and sulci, numerous gyri and sulci, they are seen here, and they are also seen here, and in the coronal image you can see it here compared to the opposite side. Then schizencephaly means that there is a defect in the cerebral cortex, and this defect is filled by CSF and lined by cortex. This defect may communicate with the ventricle and may not communicate with the ventricle. You should remember that schizencephaly is a defect on the surface of the brain lined by cortex. The defect is filled with CSF, and the margins are lined by gray matter. If the defect is communicating with the ventricle, this is known as open lip type. If the defect is not communicating with the ventricle, this is known as the closed lip type. In order to diagnose schizencephaly, the defect should be lined by cortex. And you see here a CSF-filled defect which is lined by cortex and is communicating with the ventricle. This is open lip schizencephaly. And here is a closed lip schizencephaly which is not communicating with the ventricle, with characteristic ventricular diverticulum corresponding to the site of the cleft. And this is also a schizencephalic cleft which is not communicating with the ventricle lined by cortical tissue in the axial and in the coronal plane. And here is an example of closed lip schizencephaly not communicating with the ventricle and also lined by cortical brain tissue. This is an open lip schizencephaly, a very big defect on the surface of the brain, directly communicating to the ventricle. And this is also a type 2 schizencephaly, which is communicating with the ventricle of the open lip type. And you see the gray matter lining the fissure. This should be differentiated from the porencephaly, which is a cyst communicating with the ventricle, and this cyst is not lined by cortex, and it is not usually reaching the surface of the brain. Then this is a bilateral open lip schizencephaly, a small one on the left side and a wider one on the right side. But the most important issue here is you see the gray matter which is lining the cortical defect. This is bilateral open lip schizencephaly with two big defects communicating with the ventricles. Finally, we can divide the cortical formation disorders into three stations. The first one is the stage of proliferation, where you can got hemimegalencephaly, cortical dysplasia. Sometimes they include tuberous sclerosis in this category, and the tumors including ganglioglioma and this embryoblastic neuroepithelial tumor. The stage of migration, you can be faced by subependymal heterotopia, nodules in the wall of the ventricle, focal heterotopia, mass of gray matter within the white matter, band heterotopia, which is the double cortex, and lysencephaly, which is a gyre. Then organization of the cells at the final destination. If there is any abnormality, you can get polymicrogyra and schizencephaly. We can use this table just to remember the abnormalities. You have three gyral abnormalities: agyra, brachygyra, polymicrogyra, and the three types of heterotopias: the subependymal, the focal, and the band. And the three other lesions which are not included in both, which are hemimegalencephaly, schizencephaly, and cortical dysplasia. Thank you very much. Alhamdulillahi Rabbil Alamin.